I'm going to talk about improving global awareness and management of thrombosis. Fairly light-hearted. Before we start, I want the juniors to tell me, not the seniors, thank you, what percentage of deaths globally are due to thrombosis?
What percentage of deaths?
So, yes,
30%.
globally. Sorry?
30%.
18.5%, 30%, 20%?
25.
Thank you. Very good. And so if we look at VTE, what percentage of VTE or hospital-acquired clot? Juniors?
17%.
17?
65. 55.
Okay, we'll take 50, somewhere between 55 to 60%. So us working in hospitals are responsible for most of VTE. So if we look at the figures, the World Health Organization every 2 years does a guesstimate of how many deaths there have been annually and how people died. So if we look at the most recent one, 55 million died in a year, and 12 million died of a cardiac cause, 10 million died of stroke. And if we look and break down those figures, about a quarter of the deaths globally are due to thrombosis, which makes it really the number one cause of death, especially if you tie it in with bleeding deaths due to trauma and other things. It makes thrombosis and hemostasis the number one cause of death globally. Now, the thing about the WHO is when they produce their figures, they do nothing on venous thromboembolism. They do not recognize it as an entity. So if we look at the world literature, we've got some estimates from prevalence studies on the ground, from autopsy studies in hospitals, that there's probably about 500,000 deaths every year in Europe due to VTE. And the States figures aren't quite so good, probably about 300,000. And so probably globally, we've got 3 million people dying of VTE. And remember, 55 to 60%, so that's somewhere between 1.5 and 1.75 of a million are due to hospital admission. So I think we all know that VTE is more common as we get older. We've got an aging population, especially in the developed world, so it's going to become even more of an issue. And then when we look at VTE and we look at how we manage it, we put people on anticoagulation. So this is looking at the death rate from a registry. And actually, we've got a significant percentage of people dying of bleeding as a consequence of their treatment for VTE. So this just adds to the number. And then we've got our long-term problems, always forgotten about VTE. Everyone seems to concentrate on the death. We've got that long-term risk of chronic thromboembolic pulmonary hypertension. The New England Journal paper from Prandoni and others suggested it was about 3%. And then we've got ongoing post-thrombotic syndrome. I think the literature on post-thrombotic syndrome is really just starting up because we've got just 2 scores to look at post-thrombotic syndrome. Neither of them are perfect. We've got the Ginsberg criteria and the Valalta score, which is what we use at St Thomas's. And if you use Valalta, about 50% of people after a DVT will have post-thrombotic syndrome within a couple of years, or some aspect of post-thrombotic syndrome. And then we've got the cost. So we've got health economics. If we look at the financial burden of VTE in the States, the estimate is that it costs about 12,000 to 15,000 in those treated and survive. We've got subsequent complications, and somebody came up with a cost that it's about 7 to 10 billion as a conservative estimate in the States.
So there's 12 to 15,000. Does that include the expensive bills of American doctors, or is this the cost for the government, or?
It's the cost of the care. It's not the cost to the patient. So not days off or anything. And then we have to remember with cancer, increasing burden of cancer, VTE is the second major cause of death after the cancer itself. 1 in 10 patients with cancer will have a VTE at some stage in their illness, usually early on during treatment, especially those with metastatic disease. And this comes with a considerable cost, according to the French. I know Agnes Lee will no doubt tell you a lot more tomorrow. So I just wanted to introduce a little bit of light atmosphere. So I want to tell you about what we've done about it in England, and then how we can take this out to the rest of the world. So I was talking earlier in my earlier talk about how you need to talk to everybody, really important. And my husband is an anaesthetist, was an anaesthetist, you can see him there. And I used to go on a lot of anaesthetic conferences with him. There was one every year in the Alps. And I don't know if anyone else was married to an anaesthetist, but my God, they know how to enjoy themselves. So they would be all dancing, drinking, smoking. And I was sitting at the bar, absolutely bedazzled. And I was sitting next to the guy who's just there. And I said, isn't this amazing? I said, yes, because I don't do anything like this. My wife's out there, and I said, my husband's out there. He said, I actually work on DVT. And I, really? So do I. So I've not met you before. And his name was Professor Alan Moody, and he was a radiologist, and he'd come up with a new method for looking for DVT on MRI. So it's direct thrombus imaging. You run a sequence, and with T2, you can actually see the thrombus as a white mark, as you can see in these legs. And he wanted to develop it further. So we sat and chatted in this very noisy nightclub. And after that, when we came back to England, we met up and said, we've got to do some work to improve MRDTI. We need to do some clinical trials and demonstrate that it's better than ultrasound. So we wrote a grant. We sent it off to the British Heart Foundation. We sent it off to Wellcome. They also, this is a really good grant, but we don't fund work in venous thromboembolism. So we said, what are we going to do? Let's set up a charity. So it was Alan's idea. We called it Lifeblood. We had a friend who was running a charity and whose father had died of VTE. So she became our chief exec, had a little bit of money, and we set it up. And we started aiming to increase awareness of VTE and to get funds in to get us some research grants, really to raise money. And a friend of mine who's a bit of a celeb went into the jungle from I'm a Celebrity, Get Me Out of Here that following year, and she made us her charity. And so every time somebody phoned up, 10p from the phone call went to the charity. So overnight we went from a very small charity to a medium-sized charity. So we started having money, being able to do things. So we founded in 2002. Now I have to say that Alan got so disillusioned with the UK funding systems that he emigrated to Canada, and he's now the chief of radiology in Sunnybrook. So I carried on. We set up the charity, all about thrombosis, increasing awareness, improving research, and very tightly knit group of us. Everyone contributed, really like a terrorist cell. We did our work. No, if there was dead wood, they were chopped off. And over the years, we've become the patient voice for VTE, and we started National Thrombosis Week so we could go out and hold meetings, tell everyone about thrombosis, and put messages down the wire so we could get the media involved. So we wanted to increase awareness, and we've got 3 groups of people. We've got the general public. They need to know about thrombosis. They actually need to know that 1 in 4 deaths globally are due to thrombosis, they need to know that going into hospital means you've got a high risk of VTE. Healthcare professionals, always short of education, and then the politicians and the healthcare policy makers to put VTE prevention and other issues higher on the healthcare agenda. So we were starting to raise money, and then we became aware of the issues around hospital-acquired VTE and the fact that probably Anders Cohen had estimated it was causing VTE was causing 60,000 deaths a year in the UK. If you think that 55 to 60% are due to hospital-acquired, that means 32,000 deaths due to hospital-acquired. You're not going to save everybody with thromboprophylaxis because probably efficacy in medical patients about 50%, 60 to 70 in surgical patients. Some people with end-stage cancer are going to die anyway. So we probably could save 25,000 lives a year if everyone got thromboprophylaxis. And so we looked, and it really is the number one patient safety issue because things like hospital-acquired infection have a maximum number of deaths at 10,000. It's much less now because there's been a lot of work on it. So we worked with the all-party parliamentary thrombosis group. So this is John Smith MP. He'd started this group after one of his folk in his area had a son who died when getting off an aeroplane. And Anders Cohen had been talking to him. We said, actually, the number one cause actually isn't anything to do with getting on an aeroplane. It's to do with hospitals. AJ Kakar got involved, and we actually went to see the chair of what we call our Health Select Committee at that time, Richard Taylor. Richard Taylor was a doctor who'd got in as a member of Parliament because they were trying to close the local hospital, Kidderminster. So we talked about the fact there were 25,000 preventable deaths and it just wasn't happening. If you audited what went on, only about 40% of the surgical patients and less of the medical patients were getting thromboprophylaxis. We had a sandwich lunch. The following day we wrote an emergency proposal forward, and there was a Health Select Committee organised, and it asked in December, why are so many people dying from a preventable and treatable disease? Many of us gave evidence, and then in March they produced a report, and of course the papers had an actual field day, as you can see. And you have to ask, why was there this problem? Why had we got this systematic failure of prevention? So actually most health professionals weren't really aware. Undergraduates weren't being taught well. There was no routine prevention strategy in the UK. And of course it's often a silent disease. 80% of DVT are clinically silent. They may have pain. They certainly don't have that big fat swollen leg you see in the surgical textbook. And of course most PE are detected after death. And at this time in the UK, we dropped the number of post-mortems. So when I was a house officer, when the dragons were on the earth and everyone was wearing skins, every time there was a death on the ward, there was always a post-mortem, and after you did your ward round, you went down. And the number of times you said before you saw the post-mortem, I think this was heart failure, and actually it was PE, was extraordinary. And then there was a prevalent view among many of the consultants, they don't see it anymore. Well, of course they don't, because when I was a house officer, you were in hospital for 3 weeks after you have a hip replacement. These days it's 3 to 5 days. And so people are going home. The average DVT is day 7 after surgery, so long gone. And then the average PE is day 21. And quite often the GP doesn't even consider it as a diagnosis and will put a myocardial infarction on the death certificate. So the Health Commons Health Committee report came out and said all patients, both medical and surgical, who are admitted to hospital should undergo risk assessment for VTE. And so we started lobbying, and we worked with lobbyists because you have to. And you have to learn their way of thinking and how you can sell yourself. Life is all about selling yourself, really, isn't it? I'm selling myself and my products to you. So you think about your cause, how you can sell it, who you need to talk to. You have to sell it to them in the way they understand. So when I go and see an MP, I'll say, this is what I want to talk about. Then I'll say, so this is actually what I'm talking about. Then I'll summarise at the end. So I said it 3 times so they get it. Yeah, we need to do that because you don't remember things if you just hear it once. So we campaigned and we went for a tripartite view. So that's the charity representing the patients, people like Rupen at the back, the healthcare professionals, then also the politicians. And we went together and we pushed and pushed. And by the summer of 2009, remember we started 2004, we thought we were getting somewhere, but unfortunately at a big VTE summit with the chief medical officer and the politicians all there, we wanted mandated risk assessment because doctors, when you tell them to do something, don't always do it. We have to mandate it. And Bruce Keogh, who's the medical director then and now, stood up and said, well, this is all very good, but we've got too many targets. We can't have another one. And I was sitting next to the president of the Royal College of Surgeons, and I elbowed him, and he stood up and said, yes, I'm a doctor. We want some new targets. Please give us some. Amazing, isn't it? So we built a momentum. We talked to the right people, you're educating the health professionals, you're talking to the politicians, and eventually we got there. Lots of documents on VTE prevention, nice guidance there, really important. And we got a sequin target on VTE. Now I think most of the seniors here are going to start dozing because we have had to address this. What does it mean? It meant that we were all accountable for risk assessing every single adult admitted to hospital. We had a risk assessment tool, not validated, but it was made, we used it. And if we failed to risk assess 90% of the adults, the hospital would lose money, big money, 1.5% of all of their income. So that is a very powerful incentive for the managers to get involved, or the trusts set up risk assessment tools and systems to deliver risk assessment and appropriate thromboprophylaxis. So when we look at this systematic delivery, and now we have to do 95% risk assessment, got taken up very quickly, it has had probably a major effect on the death rate due to PE. So if we look at the projected death rate, it's actually fallen by about 9%. So one has to be very proud to be in the English system because it's the first time anyone has systematically taken out something and delivered it as a nation with a fairly dramatic effect. Lots of fun had along the way. Now, before I move on about taking it out globally, the other thing the charity has been pushing on is the evil chair. So you are all sitting there, immobile. You are just preparing your bodies for a DVT. So we've got this gorgeous study from HITOS, just sat people in chairs, looked at blood flow through their popliteal vein. It drops by 50% after 90 minutes. And Richard Beasley, who's a respiratory consultant in Wellington, New Zealand, has done a whole load of work on seated immobility syndrome. So he uses this to encompass all of those situations where you're sitting for prolonged periods, and it includes e-thrombosis, which is sitting for long periods in front of your computer. Next time you see someone with DVT, ask them how immobile they are. You'd be really surprised. So we had a barrister over Christmas who nearly died, and he spends all his day doing medical legal work. He doesn't move. He doesn't get up to go to the toilet. He doesn't have lunch. and therefore he is a prime candidate for DVT. Anyway, Thrombosis UK, which is now what we call ourselves. We've moved from Lifeblood to Thrombosis UK. It's expanding, and we're continuing to do quite a lot of things to increase awareness through a website, which is addressed to patients and to you if you have a look, and we run educational meetings, particularly in National Thrombosis Week, which is the second week in May. But we have issues because the UK has devolved healthcare systems. So we have NHS England, we follow NICE guidance. We have Northern Ireland that follows NICE. It's tiny, it's 1.7 million. They're very short of haematologists, and out there the nurses usually deliver on VTE risk assessment. Then we've got Wales. So Wales is bit more of a talking shop. They too have had a health and social care committee meeting in 2009. They said we've got to do something about VTE risk assessment, but we can't do the same as the English. So they are doing root cause analysis and all the cases of hospital-acquired thrombosis. It's slowly permeating the system. So they're being informed about what cases of hospital-acquired clot are preventable. But the real bugbear is Scotland. Now, I was talking to someone earlier from Aberdeen. Oh my God, the Scottish. They won't do the same as the English. They won't impose anything on their doctors. They've got their own guidance. They've got the sign guidance. We don't use NICE. And they tried with a campaign since 2011 to improve patient safety in hospitals. So they've reduced the incidence of sepsis, but they've done bugger all about reducing the rate of hospital-acquired VTE. Total failure. So we have been up, a group of us, to talk to our new chief medical officer in Scotland to get a chink of light in, to say, would you please do something? You know, you're failing. The rate of VTE is going up in Scotland. This is Catherine Calderwood. She used to work at St Thomas's. She did her research on VTE in obstetrics. And so we got her to deliver a statement on World Thrombosis Day to say, we're going to improve things in Scotland. So we're on the back of Scotland. You warn them when you go up there. So you've got to engage with policymakers, because the only way to reduce the rate actually is mandation. So the other things we do is we've got awareness campaigns, and our current one is we've got a really good photographer who's taken pictures of those who've got post-thrombotic syndrome, who've been psychologically traumatized by VTE, and we've got a load of photos that are going and doing the rounds. So we have a system that delivers VTE prevention. It needs to go out globally, and the ISTH have been amazing. They have set up this thing called World Thrombosis Day. World Thrombosis Day is October the 13th. Does anyone know what happened on October the 13th? Sorry? It was Virchow's birthday. Virchow, the father of VTE, who described the triad. So this is sort of mirroring what we have done in NHS England, but on a global scale. So it's a global movement to put the spotlight on thrombosis as an urgent and growing health problem. So this is the mission statement, very similar to Thrombosis UK. And also looking at the WHO. The WHO have set this target of reducing non-communicable diseases between 2013 and 2020 by 25%. They're not going to do it without mandating VTE thromboprophylaxis globally. So there's a group of us. We're due to meet up next week. Somebody from every continent, sometimes more than from every continent. So we're a group of academics. We have to start with science. So we've done a burden of disease study. It's a systematic review trying to work out the exact incidence of VTE in low, middle and high income countries. And we published it at the same time as the World Thrombosis Day in 2000, or shortly before, in 2013, and it was published simultaneously across all the thrombosis journals. To bring home this message, we have got to sell VTE as being an important cause of death. So we've got an instance from the work we did. It's somewhere between 0.75 to nearly 3 per 1,000 population, obviously increasing as you get older, but not confined to the elderly. And then we actually managed to pull out the fact from WHO data, though they don't recognise it, that hospital-associated VTE is a leading cause of disability-adjusted life years in low, middle and high-income countries. So people are going home, they're having VTE, they're being left with post-thrombotic syndrome, which is very difficult to deal with. And we've also done a global awareness study. So we contacted Ipsos Mori, and they went across 8 countries and asked the general public, how much do you know about VTE? Well, I haven't put the survey result on here, but I'm smirking somewhat because in England and Wales, 80% of people know what a DVT is and can describe some of the symptoms. Over 50% know what a pulmonary embolism is. If you go to the States, if you go to Japan, if you go to Holland, it's somewhere right down about 20%. So we like to think that the work that has been done over the years has improved awareness. So on World Thrombosis Day, we have partners, people who've signed up. Everyone is trying to run an event in their country, and I hope you will go back and think about doing something on World Thrombosis Day from little to big. We have a national meeting with Thrombosis UK every year. We do a lot on Twitter and Facebook, and we have improved over the years. We've got a brilliant website where last year we talked about keeping life flowing. And we've also got to start campaigning. So this is a picture of failure, unfortunately. So I started off and I went to the WHO and I went to the non-communicable disease section of the WHO to talk about VTE. The meeting is very organised, 3 minutes to talk about VTE. I took with me the health economist from NICE who works on VTE, Dahlia Darwood, and we did our little spiel, and afterwards, feeling very pleased with ourselves, we sort of hung around, and several people came up and said, "What are you doing here? It's the wrong place. You need to go to the patient safety area." So we suddenly realised we can't just go, and they're not going to listen to our words. We're going to have to campaign again. So we're setting off on another path. It's going to take a few years, but the aim is to get the WHO in their patient safety area to say, please countries, will you mandate thromboprophylaxis in some form or another? So we've got a number of steps to go to, and again we want to use that same approach. It's patients, it's health professionals, and it's people with a political agenda to work together to push it on. So the next few steps, we need to understand really why the WHO on their patient safety area don't have anything on VTE prevention. So they've got a lot about safe prescribing and sepsis, but they have nothing on VTE prevention. And the head of patient safety is Liam Donaldson, who was the chief medical officer when we mandated thromboprophylaxis in the UK. So what's going on? So we need to find out a bit more. We've got to mobilise patient groups. We've got to foster some relationships between those who are on the WHO executive. They've got to meet with everybody. We have got, again, to build up a momentum, and eventually we hope we will be able to persuade the WHO to take on thromboprophylaxis globally. So that's it, really. I don't know how long it's going to take us, but that's where we're starting from. Thank you very much.